Good evening, dear friends. Welcome to this first webinar of Diabetes in Elderly Interest Group, concept by Diabetes India organization of our country. And we are lucky to have the Secretary of Diabetes India and who is the brain behind this concept of creating interest groups, Dr. Bansi Sabu. So I will first request him for his welcome address for this webinar.
Thank you, Partha. First of all, thanks for doing this program. Now, let me talk about the Diabetes India in first 1 minute. That this is the organization which is almost like 25 years old. It has been started as a research trust of Diabetes India by Dr. late Shokat Sadikot, who was also the past president of International Diabetic Federation. Dr. Shokat Sadikot thought of that we should have an organization from India. We should have a very catchy name, and at the same time, it should have a very, the international collaboration of that association should be very high. That was his dream, and that's the reason it is slightly different than what RSSDI. And we started from its time when it was born. From that day, it was a part of International Diabetic Federation, and Dr. Shokat Sadikot also very actively involved with International Diabetic Federation. From 2006, in early days, when I was also the part of RSSDI, but I started simultaneously working for Diabetes India. And from 2013, I am taking care of it as a Secretary General for Diabetes India. Every year, we do the meeting of Diabetes India, but different activities which we plan under the banner of Diabetes India. This idea of creating an interest group was that, there are few sub-speciality of diabetes where some of us have more interest in compared to the other thing. That does not mean that we are not practicing. Like suppose you are or me to whom I can see in a diabetes in elderly group, that does not mean that you don't take care of pregnancy or you don't take care of newer technology or you don't take care of type 1 diabetes. But we know that these are some of the subspecialty, and these subspecialty, if some of us who have a common interest and if we have a more discussion, probably we will come out with a better care for these people. So diabetes in elderly is something which an area which I personally feel it is neglected. Actually, geriatric medicine overall, while I see always Dr. Vinod Kumar, who was a professor of medicine, and then he was a professor of endocrinology and diabetes, and he was also having a huge interest in geriatric medicine, and he developed department of geriatric medicine, and now he's practicing till as a geriatric medicine expert along with the diabetes. So we have very few persons who are actually geriatrician in our country or who are taking this geriatric medicine or diabetes in elderly group, how to treat it. So there are many things which we can do with the experts who have worked in field of geriatric medicine. I think they position statement, what are the extra care which we have to take. So normally we moved in diabetes management from glucose-centric approach to prevention complication approach and then to overall metabolic care. But I believe someone who is elderly, suppose at the age of 70, do you have the same targets? I don't think so now. At the age of 70, you need to think that glucose control is fine. Yes, prevention of complication is okay. But now you want that this person should not fall and he should not develop a fracture. He should not develop the complication which will create his life miserable. I mean, something which should be giving him more happiness rather than your idea of controlling glucose. So I think there is a completely different targets has to be done. And that's the reason different interest group we have created. And I'm sure by doing multiple webinars and seminars and come out with some position statement, doing some more meeting each other, like I have already invited in our DiacareCon for all the experts who are taking care of this group, we can have a brainstorming that what are the things which we can do. We have already done one meeting in Indore, and because of that, now we all are meeting. So probably in coming years, when we will be meeting more frequently, we can think of something more. Now, there are international such groups are also there. So it's not like that we are only done. It's American Diabetic Association. So we have already written their interest group and our interest group can have interaction. We have also different population. I mean, some part of the Western world, they think only above the age of 80 is considered elderly, while in India, above the age of 60 or 65 is considered elderly. So, completely we are different, and where we can have a common things. And as a physician, as a diabetologist, do we need to know about the prostate also? Do we need to know more about the bones? Do we need to know more about the infection? Do we need to know more about the vaccination? So there are many things which is, I think, required. And this closed group meeting and with collaboration with international society and international groups, which they are also having in some of the organization, I think we will come out with a better care for our patients or the persons with diabetes and who is elderly, where I will call elderly here is more than 65. The treatment may be the different for them. The way which we treat in our clinic, you and me, we all try our level best to treat them in a most efficient way. But still, there are a lot of lacuna which I can see. I mean, are we really treating them so aggressively? Are we treating not only the glucose part? I'm not talking of the glucose part. I'm talking of something else which we are doing or not. Are we thinking of they're developing postural hypotension? How many of us are actually doing for their autonomic nervous system function test? If somebody is 15 or 20 years of diabetes, are we checking their blood pressure for postural hypotension? Are they getting giddiness is because of that? So there are so many other issues which are maybe small issue, and they have psychosocial problem also, and the cost may be the problem and all these things. So this group is going to create a lot of things for India. And once again, congratulations, Pratap and Ami, both of you, that under the guidance of such a legendary person with us, you have Dr. Vinod Kumar, and we are so lucky that he's always available to us, and all the time his blessings is there. Not only his blessing, he still is intellectually, he is so intelligent that, I keep on reading whatever the message which he keeps on sending us on our patron group or in past president group of RSSDI. So, we have his vision and his blessings and his experience. Everything will count here. And we will have, this group will become very active. And probably if any group will become active, the others group will also try to see that what they are doing, they will also start doing. So that's the idea of doing it. Once again, thank you, Pratap and Ami, for inviting me also. And I'm sorry that today I will not be available for the full meeting because of some social commitment which I have done. But thank you very much. Once again, thank you, Ami, Pratap, and Pranam to Dr. Vinod Kumar, sir. And thank you very much.
Thank you, Dr. Bansi, for sparing your valuable time and welcoming all the people and giving them idea about creating these interest groups. We are missing the company of Dr. S.R. Arvind, who is president of Diabetes India, is busy with IDA primer meeting at Bangalore. And we are also missing the company of Dr. Amit Gupta, who is coordinator for all these interest groups. Today he is having his birthday. So on behalf of Diabetes in Elderly Interest Group,
so, all three of us are engaged somewhere, but Pratap, it is not like that. Who is what? I mean, you people are doing it. That is more important.
Yeah. So I am also at Trichy, but still we are running the show. We are running the show. So we wish a very happy birthday to Dr. Amit, and we look forward to meeting him at the DiaCareCon for further inputs about activities of Diabetes and Elderly Interest Group.
So now we have already written a mail to everyone, and I'm sure that we will have a good board meeting, and you can plan, and you can also write to other groups also, in a concrete plan, and what we are going to discuss in half an hour. We don't want to waste your time, and let us come out with a concrete plan and do something for next year. In next 3 months or 6 months, we should do something for that.
Okay. Yes,
right, sir. Thank you.
Okay. Thank you. Now I will invite our Chair of Diabetes in Elderly Interest Group, Professor Vinod Kumar, for his welcome address for this webinar.
Okay. So let me listen, sir, and then I will go.
Thank you. Well, I will first like to welcome as well as thank the committee members of this group and also all the members, whosoever is attending or whosoever is going to attend this important webinar. We have tried to keep this webinar very simple and understandable. There are two different kind of specialists who are going to attend and participate this webinar. Thank you, Dr. Bansi, for kick-starting and giving a very good background and introduction about the objectives of various interest groups. And I am also aware that the interest groups are very prevalent all over the world, not only in the field of diabetes, but in the field of many other medical conditions and even non-medical conditions. And the primary objective of this interest group is brainstorming by different people from different facets of life and add to the knowledge and wisdom of that specialty. So with this, I would once again thank you, and with permission of Dr. Jetwani, can I hand it over to our moderator, Dr. Amit Sanghi.
Thank you, Professor Vinod Kumar sir, for welcoming our delegates. I will request RX Events to run the CV slide of our faculties. Before that, I will welcome the moderator of today's webinar, the first webinar of our interest group, Dr. Ami Shangvi. She is MBBS Diploma Diabetes and Fellow of Diabetology. She is Director Consultant Diabetologist at Mumbai, and she is lecturer also for CPS Diabetology. She is very active in the field of diabetes and women, and she has been invited at almost all national conferences across the country for our presentation related to diabetes. So without wasting much time, I hand over to Dr. Ami for running the show for today's webinar.
Ami, thank you and congratulations.
Thank you so much.
I'm leaving now. Sorry for this.
Sir, have a great evening ahead. Thank you so much, sir.
Thank you, Dr. Bansi.
Thank you, Bansi.
So a very good evening to everyone present here. Thank you, Dr. Jetwani, for those kind words. And thank you, Dr. Bansi Sabu and Professor Dr. Vinod Kumar for those motivating words for us to begin with the first webinar of our special group, Diabetes in Elderly. Today's discussion topics are going to be geriatric syndromes and hypoglycemic fact of geriatric syndromes in elderly population. So geriatric syndromes are a collection of medical conditions that are commonly observed. So these syndromes tend to be interrelated, and addressing them requires a holistic approach that goes beyond treating these individual symptoms. And for this, we have the most efficient person who can be talking on this, Professor Dr. Vinod Kumar, who is a patron of Indian Academic of Geriatrics and of RSSDI, receiving various multiple awards from the Government of India, the Delhi government, Lifetime Achievement Award from Diabetes, from RSSDI, from Indian Aging Congress, various publications and consultations always available to us for his guidance, and been a member of many boards. Without taking much time, I invite you, sir, to take over the first session.
Thank you. I would first like to share the screen, and can you see my first slide?
So you need to go to the slide mode.
Yes, I'm doing that.
Yeah.
Is it okay?
Yes, sir.
Okay. Well, as a first speaker, I would like to talk in simple terms, not only about the geriatric syndromes, but about their impact as far as the elderly diabetes are concerned. We all know that elderly diabetes differ from younger diabetics in an overall approach. There is a higher prevalence of geriatric syndromes in them. There is a greater risk of hypoglycemia, frequency of hypoglycemia unawareness. There is a higher glycemic variability in elderly diabetics, which contribute to poorer control. And there is also higher vulnerability to the effects of hypoglycemia, like cardiac arrhythmias, myocardial infarction, neurocognitive dysfunction, falls, frailty, and death, etc. Now, these are the geriatric syndromes. There are many geriatric syndromes which have come up and crept up in the literature from time to time. It might be interesting to tell you that the first person who coined this term, geriatric syndrome, he coined the term as geriatric giants in 1965, was Professor Bernard Isaac. And he at that time named 4 geriatric giants. One was impaired intellect, other was immobility, and third was imbalance, that is instability, and last one he named as incontinence. But over the years, more and more geriatric syndromes have been added up. And what I am going to talk about, 7 geriatric syndromes that have been enlisted here. Dr. Amy has already said that geriatric syndromes are conditions in elderly that do not fit into specific diseases, and most of them complicate the care of older diabetics by interfering with their self-managing abilities and leading to a poor quality of life. I would be talking of impaired intellect, that is dementia, immobility, that is a part of frailty, inappropriate medicines, also known as polypharmacy, impaired vision and hearing, that is sensory obtundation of different kinds, imbalance or instability, that is falls and fractures, incontinence, notably the urinary incontinence, and sleep disorders, including insomnia. Now, this is about the dementia. This is the first geriatric syndrome, and I think of greatest concern to a diabetologist. The dementia warning signs in brief are memory impairment, problem of perception, reasoning, attention and concentration, difficulty in right thinking, making judgment is also a problem, and communication or language is another problem. And these important warning signs should be severe enough to interfere with a person's ability to function day to day, because some of these functions may be even present in non-demented elderly people. But this is not amounting to interfering with daily activities of living. So it is an umbrella term. Dementia is an umbrella term used to describe a set of symptoms, the changes of which I have told you. And as we all know, diabetes and its many complications and associated comorbidities like hypoglycemia, CKD, hypertension, stroke, obesity, dyslipidemia, and even CLD themselves are risk factors for dementia. Now, what happens when dementia creeps up in the life of a diabetic elderly, or vice versa, that an elderly diabetic gets dementia during the course of his diabetes? So if diabetic patients, when they develop dementia, they can forget taking medicines or forget that they have already taken, and there is a risk of taking twice. They may forget taking meals, which is a harbinger for hypoglycemia. They may forget taking liquids, which can lead to dehydration. They may have indecision in adjusting the insulin dose, or may even take a wrong dose, which may subsequently followed by hypo or hyperglycemia. They may forget how to do an injection or unable to identify even their medicine. On the other hand, when the dementia patients develop diabetes during their lifetime, what can happen? They cannot find toilet in the house and develop risk of incontinence, because in diabetes they have to frequently go to toilet. Secondly, that they are vulnerable to increasing falls, leading to injuries and fractures due to visiting and looking for toilets in the dark sometimes. If there is hyperglycemia, dehydration can set in because they forget taking liquid, and this can lead to greater confusion or even somnolence. They may have inability to put their distress in words, so they may cry or shout out. So whenever such things are happening, if a diabetologist or a geriatrician does screen for dementia or should screen for dementia by Hindi mental examination, HMSC, or a short test like mini-cock test, and there are many other tests, and if necessary, further referral to the expert is needed. This is the second geriatric syndrome, frailty. What are the warning signs? Weakness, it may be subjective. Slow walking speed, there is an instrument to decide whether the walking speed is slow. Low level of physical activity, fatigue or exhaustion, or unintentional weight loss. And how do we, and as I said in the bottom, it is written diabetes and even some anti-diabetic agents which promote weight loss, they can be risk factors for frailty, because weight loss is an important feature of frailty. So this is about the impact that can happen in the because of frailty on diabetes in elderly. On the left side, a small diagram shows that diabetes over the year can lead to slowly increasing muscle loss. And with this muscle loss, they would also have slowly advancing functional limitations of various kinds, which can lead to disability. So that is over the years a spectrum of frailty. This might be creeping without person or family knowing about it. Frailty is a state of limited reserve. It is not simply weight loss and weakness that any elderly person can suffer. It is also leads to falls and fractures. It is linked to inferior treatment outcome on high risk of hypoglycemia among elderly diabetics. It is therefore important to rule out frailty in at least people who are aged 70 and above, and there are well set criteria for screening for frailty. Any anti-hyperglycemic agent which causes excess weight loss or linked to high risk of hypoglycemia or linked to fracture should be discouraged if a patient is found to have frailty. Very briefly, proper nutrition, physical activity monitored, and education on self-care for diabetes has to be instituted. Now, screening for frailty, one of the very popular instrument is published by Fred long time back in 2001. Again, as I said earlier, there are 5 parameters. Mobility is tested if a person is unable to walk 4 meters in 6 seconds. Strength is tested, and if it is found that grip strength is less than 12 kilograms for a male or less than 7 kilograms for a female, it means he has less strength. Nutrition means equal to or more than 4 kilogram weight loss in the past 1 year. Energy means self-reported exhaustion for at least 3 to 4 days in a week, which is purely by asking the patient. And physical activity means zero weight bearing, like climbing stairs, or more than 6 hours sitting or lying in the hours when he is awake. And 1 point is assigned for each of these parameters. If there are 3 points positive or more than 3 points positive, he is labeled as frail. If 1 to 2 points are positive, he is pre-frail. And if none of them is positive, he is a non-frail or a robust, normal elderly individual. Coming to the third geriatric syndrome, polypharmacy warning signs. There could be autonomic like hypoglycemia, orthostatic hypotension, syncope. Central nervous system could be lethargy, confusion, somnolence, and even extrapyramidal symptoms. Gastrointestinal symptoms are very common: dry mouth, diarrhea or constipation, bloating or flatulence, and cardiovascular system symptoms could be tachycardia, CHF, edema. You all know NSAIDs can cause edema and fluid retention. So I think this polypharmacy is because of many things: drug-drug interaction, adverse drug reaction, drug-disease interaction, and so many things, and altered pharmacokinetics and pharmacodynamics in elderly people. So if there is a polypharmacy, we call polypharmacy if a person is taking more than 4 drugs, that is 5 to 9 drugs. And if a person is taking 10 drugs or more than 10 drugs, then we call this as extended polypharmacy, also known as heightened polypharmacy. And if there is a polypharmacy, there are now schools of thoughts that we may go according to standard procedures of de-prescribing these medicines, which may be quite helpful. Of course, in elderly people, particularly diabetics, many medicines are needed, but sometimes the medicines are unwantedly being taken without any need. For example, if there is an adverse reaction to a medicine, instead of stopping that medicine, what people are doing, that people are adding another medicine, thinking that some other disease or problem has cropped up. So this is about the impact of polypharmacy on diabetes in elderly. The prevalence of polypharmacy among elder diabetics is more than what is seen in non-diabetic elderly people. It amounts to more than 60% these days. It is true. Polypharmacy strongly impacts on adverse health outcomes among older diabetics. They may increase the risk of poor diabetic control and hypoglycemia. They may also have a higher risk of falls, hospitalization, and death. This diagram which I am trying to show is the blue bar represents no diabetes in elderly people. The orange bar, it indicates diabetes people, and the green bar indicates those diabetes people in whom the data has been shown without anti-hyperglycemic drugs, only those drugs which they are taking for other conditions, although they are diabetic. So you will find on the left side, 35% of non-diabetics are taking zero drug. No, they are not taking any zero drug. But only 4.1% of diabetics who are lucky enough not to be taking any drug. When you jump to 5 to 9 drugs, which is polypharmacy, you will find 14.8% of diabetics are taking as many as 5 to 9 drugs. But 14.8% non-diabetic, but 50.2% diabetic elderly are taking 5 to 9 drugs, labeling them as polypharmacy. But extended or heightened polypharmacy is also eye-opening. Only 1.7% of non-diabetic elderly are on 10 or more drugs, but as many as 10.2% of elderly diabetics who are taking 10 plus drugs. And these tendencies and trends are in spite of patients if you exclude anti-hyperglycemic drugs. So polypharmacy is a real issue. Now, next is hearing or vision loss and its impact on diabetes elderly. Some people do not regard it as geriatric syndrome, but others do. Prevalence of self-reported vision loss among persons aged more than 60 years is 34.2% according to one study among diabetic elderly versus 21.4% in non-diabetic elderly. These percentages keep varying according to different studies. Prevalence of hearing loss is even more. Above mean age 70, it is 50% in diabetic and 38.2% in diabetes. So what is the general impact? They would have certainly self-management difficulty. They have vision or hearing impairment. They would be disconnected with the society at large. Some of them may even go to the social isolation and lonely feeling. And certainly because of the vision and even because of hearing impairment, they may be vulnerable to more falls. Now, this is the specific impact of hearing and vision loss. These three figures show the incidence probability curve for patients of elder diabetic, T2 diabetes, that is type 2 diabetes, for myocardial infarction on the left side, for stroke in the middle, and for all-cause mortality on the right side. The blue line indicates the patient where both vision and hearing impairment are there. The lowest black line indicates where there is none. And the in between the two lines are either for those who have only visual impairment or for those who have only hearing impairment. You will find that those who have both the impairments, they have higher probability of incidence of getting MI over the years. And this is true of stroke, this is true of all-cause mortality also. So this is important. Now we come to the next geriatric syndrome, that is imbalance, which results falls and fractures and its impact on diabetes in elderly. Recurrent falls are indicated according to one and common definition that if there are 2 or more falls in a period of 6 months over a period of 3 years, this we call recurrent falls. Prevalence of such falls is 30.6% in elderly diabetic and 19.4% in normal or non-diabetic elderly. Again, these percentages vary according to different prevalence studies. The polypharmacy, cognitive impairment, insulin therapy, sarcopenia and frailty, neuropathy, all predispose to falls and fractures. I have a word to say about insulin therapy. It is not really known how insulin therapy can cause falls and fractures, but it is generally said that insulin, one of course easy explanation is that one can get a hypoglycemia more frequently due to insulin and can get a fall. But the other mechanism, they said that the endogenous insulin, although it is an anabolic steroid, encourages the osteoblastic activity and bone formation, But the exogenous insulin is not so efficient in that. And there are studies that when the insulin therapy is stabilized, the portal insulin does all good, but the peripheral insulin is actually encouraging osteoclastic activity and more resorption. So there are all sorts of mechanism theories how insulin is. But insulin therapy is certainly considered to be more harmful for fractures in general compared to the oral hypoglycemic agents. Although some oral hypoglycemic agents have also been cited to have minor fracture possibility, but insulin is certainly more. Then about the fragility factor. Fragility factor, by that I mean a person contracting a fracture by falling from standing height or even less than standing height. So elderly diabetes are more prone to fragility fracture than elderly non-diabetes. And this is because of long-standing hyperglycemia, which erodes into the bone density, and there are contributing factors like senile osteoporosis, vitamin D deficiencies, existing comorbidities, insulin usage again, and diabetic neuropathy plus retinopathy, because they may have impairment of vision. They all predisposed to fragility fracture. Impacts are general, delayed healing of course, self-managing difficulty will be there because of these falls and fractures, or because of falls and injuries alone without fracture. They will have physical activity limitations, so they cannot do exercise, and there might be in cases greater need of medical care or a need of change to anti-diabetic drugs. Next is urinary incontinence and its impact on diabetes in elderly. Again, according to one prevalent study, older men with diabetes experience more urinary incontinence when compared to counterparts without diabetes. Incontinence is even more prevalent among women with diabetes than without diabetes. Obesity, a comorbidity of diabetes itself, is even associated more with incontinence. Impact is there is a general negative influence of quality of life and self-health perception, physical functioning, because somebody is going to toilet again and again, is not able to sleep in the night, his physical functioning will be compromised next day. Mental health is also affected, and of course, because of the gender reasons, this is less often reported by women. Now, this is the last geriatric syndrome, that is sleep disorders and the impact of diabetes in elderly. This is something which has been added to a geriatric syndrome for last 2 years only. In the initial years after 1965, this was not a part of geriatric syndrome. So again, prevalence of sleep disorders in diabetic patients is higher. Predisposing factors include old age, polypharmacy, nocturnal hypoglycemia, neuropathy again. Duration of longer the duration, the more likely is the sleep disorder. Insulin use, again because of hypoglycemia mostly, and also because they are likely to have more hypoglycemia, that's why they are on insulin. And what is called insulin resistance related obesity, which can also breed sleep apnea syndrome. The impact is poorer glycemic control, risk of developing chronic diabetic complications in insomniac patients. It adds to diabetic stress, anxiety, and depression. Those who do not sleep well, they may also be vulnerable to falls and injuries. And it is said both too short and too long a sleep increase the risk of cardiovascular events and death. Female diabetes are considered to be more prone to sleep disorders and their impact. So take-home message is that geriatric syndromes are more common in elderly diabetics than elderly non-diabetics. Polypharmacy, problems of sleep, vision, and hearing are common but underdiagnosed and followed by incontinence, falls, cognitive diabetes by compromising with diabetic control, compromising with self-management, compromising with health-related quality of life, and hypoglycemia with its all dreadful consequences like neurocognitive and cardiovascular morbidity, falls, and fractures. Geriatric syndromes can contribute to one another in the same patient and render his life further difficult. Examples are frailty, cognitive dysfunction, insomnia, polypharmacy, lower vision, all contributing to falls, dementia contributing to incontinence, and polypharmacy contributing to sleep problem also. Geriatric syndromes, Hope's recommendation should be a part of a standard of care which Dr. Jethwani would take up on his turn. So with that, I'm very grateful for listening, and I also wish you all a very happy Independence Day. Thank you very much.
Thank you so much, sir, for this wonderful insight on the impact of geriatric syndromes in the elderly diabetics. Now we move on to the next topic about hypoglycemia and the special aspects of hypoglycemia in the elderly diabetic. And for that, I invite Dr. Meenakshi Sarda from Kota. Now, hypoglycemia has always been a challenge in all the age groups, but it can be unique challenge in the elder age factor. Now, it's crucial for healthcare providers, caregivers, and older individuals to be aware of the risk and management strategies to prevent hypoglycemic episodes. And to throw more light on that, we have Dr. Meenakshi Sarda, who is a senior professor medicine and HOD geriatric medicine from JMC Kota, and she's got various merits and awards to her credit. She's an organizational, has many organizational responsibilities at various forums, and has a huge academic experience as a convener, lot of publications, paper presentations, and chapters in various textbooks. Thank you, ma'am, for coming as a speaker here, and I hand over the session to you now, ma'am.
Thank you, Dr. Amy. First of all, a very good evening to all the participants and the speakers here available. And my heartfelt regards to Dr. Vinod Kumar for giving me such a golden opportunity to share on this platform. And I'm really grateful to him. He is a very generous person, I would say. To start my talk, I would just take 2 minutes. I'll start sharing my screen. So, with the increasing life expectancy, more and more elderly population in the elderly persons in the population, we know that the more and more number of the elderly persons are getting diagnosed with a type 2 diabetes, and simultaneously there is an increasing number of type 1 diabetic patients also who are now celebrating their 60th birthdays onwards. So this is because of the widespread awareness of the fact that diabetes, good control of diabetes would lead to or prevent its complications. So there is always a trial or the practice of the treating the patients and achieving a tight normal glycemia. But this sometimes can be very dangerous especially in an elderly population who are at the risk of hypoglycemia. Because we are now observing that, yes, I'll be sharing again. I'm just introducing my topic. with the few words why this topic is important to discuss. Now we are observing the more and more elderly number of the persons are entering in our emergency department with a hypoglycemic episode. So there is a definitely important, this time is now important to talk about the hypoglycemia also along with the diabetes. So this is my first slide. The diagnosis of hypoglycemia requires the documentation of a Whipple's triad. That is, the patient blood estimated or the measured blood sugar should be less than 70 milligram per deciliter. The patient should have the clinical symptoms and signs which are consistent with the hypoglycemia, and there should be relief of symptoms after the glucose concentration is raised. So this Whipple's triad is required for the diagnosis. In clinical practice, we just classify by saying that this patient may have a mild hypoglycemic episode, or it may be the asymptomatic or just a biochemical hypoglycemia, when we say that the patient himself is able to take care of this hypoglycemic episode. But once the patient requires an assistance, then it becomes a severe hypoglycemia, and that is more dangerous. That was just a clinical classification, but ADA work group has classified hypoglycemic events into various categories: symptomatic hypoglycemia, documented symptomatic hypoglycemia, probable symptomatic hypoglycemia, asymptomatic hypoglycemia. What is most important is a relative hypoglycemia, which is very commonly seen in the elderly population, that they have a poorly controlled diabetes of a long duration, and they may experience the hypoglycemia when the blood sugar is even 80 to 90 or 100. So that should not be overlooked. That I mean to say. Rest of the hypoglycemia categories are according to the self-explanatory words. So why this is necessary that the patients, elderly patients, are why they are having more episodes of hypoglycemia? What are the risk factors? So in a non-diabetic elderly patient, the various risk factors are either the patient is mostly on the insulin or a sulfonylurea therapy. There is a prior history of a hypoglycemia, which might have been overlooked. Along with that, because of the long-standing disease itself, the patient can have a hypoglycemia. Patient can have hypoglycememia unawareness, and there is always a blunted counter-regulatory response because of this. And associated, the patient can have a chronic hepatic or renal dysfunction also. Here I would just like to pass a passing reference to episodes of hypoglycemia can occur in a non-diabetic elderly also. And the risk factors are the old age itself, malnutrition, multiple comorbidities, acute illness, stroke or TIA, multiple medications, dementia, depression, heart failure, and the social isolation. So these are also the risk factors in a non-diabetic hypoglycemia in an elderly population. The clinical manifestation of hypoglycemia depends upon what was the current blood glucose level of the patient, role of the rate of the decrease of the blood glucose, at what rate it has fallen down, severity will be like that, the duration and degree of the metabolic control of the diabetes, how was the patient's diabetes maintained in the past period, age of the patient, more the age of the patient, more will be the symptoms or maybe the atypical manifestations we will see in the later slides. If the patient has a concomitant complications, then also there is will be those manifestations will also make it precipitated along with hypoglycemia. Previous episodes of severe hypoglycemia and the type of medication, especially the long-acting sulfonylureas. I would like to mention here that as this is the cheap drug and easily available drug and cost-effective, many elderly patients are put on long-acting sulfonylureas and they are very prone to get hypoglycemia. And this hypoglycemic episode may remain prolonged even up to 7 days. So that should be kept in the mind when the patient comes with the hypoglycemia and taking a sulfonylurea. You should not release the patient immediately. Just by one recording of blood sugar, it has come to normal. Don't release the patient. The clinical features. Now we talk about the clinical features of hypoglycemia. The clinical features initially they depend upon what are the neurogenic or the autonomic symptoms. Because whenever there is a hypoglycemia, there is an increased sympathoadrenal discharge. And this increased sympathoadrenal discharge is because of the sensitivity of the brain to a set point of the glucose level. And then accordingly, there is a sympathoadrenal discharge. And these symptoms can be adrenergic symptoms in the form of palpitation, tremor, and anxiety, or they can be cholinergic symptoms in the form of sweating, hunger, and the paresthesias. Once the blood sugar levels drop down to such an extent that the CNS or the brain is deprived of the glucose, because that is the only source of energy for the brain, the patient will start manifesting the neuroglycopenic symptoms in the form of confusion, fatigue, behavioral changes, seizures, maybe loss of consciousness, and the cardiac arrhythmias. Along with these clinical manifestations, the patient have the signs associated, that is diaphoresis, pallor will be there. Patient may have a transient neurological deficit. There may be tachycardia and the blood pressure may be raised. Recognition of hypoglycemia, we know that we cannot have an exact estimate of the elderly person suffering from a hypoglycemia, but definitely they are more than the younger population. And the mechanism for that is that it is mostly the drug-induced hypoglycemia, and the culprits are mostly the insulin and the sulfonylurea drugs. There is a decreased renal gluconeogenesis. There is the decreased excretion of the drug, leading to increased half-life of the drug and prolonged action. And this is usually the story. A patient who is a known diabetic has been well controlled with the regular follow-ups, monitoring blood sugar. He had been taking his drugs regularly, and suddenly he started with the same doses what he was taking. He started showing the episodes of the hypoglycemia. So we must think of that this is a clue that now the patient is developing a diabetic nephropathy, and the drugs initially which were tolerable to him, now he has started showing with the same doses, he has started showing the hypoglycemic episodes, and we must reduce the doses and we must confirm it by the necessary biochemical parameters. Recurrent hypoglycemia, it itself leads to a hypoglycemic associated autonomic failure, what is known as a HAAF. And there will be a blunted autonomic response and counter-regulatory response will be decreased. The counter-regulatory response, we all know that increases insulin level starts decreasing if the blood sugar goes in range, blood sugar remains in the range of 80 to 85. Glucagon, other counter-regulatory hormones such as glucagon, epinephrine, cortisol, growth hormone, they will start rising once the blood sugar is in the range of 60 to 75. And when the patient starts developing the symptoms, if the blood sugar range drops to 50 to 55 and below 50, the patient's cognition will start decreasing. There are some difficulties in recognizing hypoglycemia in the older people, and there may be confusion. And what are these difficulties? The first and foremost is that sometimes the symptoms of hypoglycemia are non-specific. Rather, I will say, as has been found in the acquired trial, these are the most common non-specific symptoms which has been reported by the elderly persons above the age of the 75 years. They will just have a feeling of unwell, the fatigue, and the weakness. And these symptoms can be attributed to the old age itself, and the patient may not be paid any attention. So that is one thing. The elderly persons, like any other disease, can have an atypical presentation of hypoglycemia. Maybe that the patient comes in the confusional state or maybe in the delirium. That is the one thing. And that's why it can be a difficult diagnosis sometimes, or it can be a misled diagnosis or the late diagnosis of hypoglycemia. Second is that the patient, we know that they have a blunted autonomic response. So there are little warning or unawareness of the symptoms, and the patient, again, they may be missed. And because these autonomic symptoms are blunted, the patient may have a neuroglycopenic symptoms only the neurological manifestation to start with, such as the visual disturbances, dizziness, and syncope. And then the diagnosis may be that it is some neurological problem, which usually the elderly patients associated have it. Lastly, the patient's agitation or behavior abnormality or the behavior change can be misinterpreted as dementia related. Elderly patients have this already simultaneously, and on the top of it, elderly patients with the dementia are unable to communicate their feelings or the symptoms. So these are the difficulties in recognizing hypoglycemia in older people. The episodes of hypoglycemia, there can be acute consequences and the chronic consequences. Acute consequences are that elders are at higher risk of adverse consequences of hypoglycemia due to multiple comorbidities, undernutrition, and polypharmacy. Polypharmacy, sir has described in very detail, and the very beautiful graph to show how many drugs a diabetic patient goes on taking, what is heightened polypharmacy. The severe hypoglycemic episode itself can lead to an acute stroke, myocardial infarction, acute cardiac failure, and ventricular arrhythmia. The main is that morbidity due to recurrent episodes of hypoglycemia is associated with the silent and chronic complications. And they are starting from the general physical functional decline to a frailty, fractures, disability, and maybe the increased risk of mortality. The general functional decline can be estimated by the Barthel index, and that index goes on becoming poor and poor. And when the score is less than 30, the patient may be totally, completely physically dependent on the caregivers. That is about the functional decline. There is an increased risk of falls. This has also been described by the sir. And with the increased risk of fall, there is increased risk of fractures, including the hip fractures. In various studies, it has been demonstrated that the hip fracture risk increases as the patient has more and more hypoglycemic episodes. This itself leads to the increased disability with frequent hospitalization. Frequent hospitalization will lead to increased fear and anxiety, increased social isolation, behavioral changes, increased panic attacks. Again, like all that will increase with any other complication the patient develops. And the cognitive function, which is most important because of the hypoglycemia, that is a chronic consequence, and there is an increased risk of dementia. And with the increased risk of dementia, there is more of a hypoglycemia. So it is a vicious circle which sets in. There will be more of a hospitalization and more of the, again, additional factors along with that. And there will be increased risk of mortality. So if we consider about the treatment, I'm not take much in detail about the treatment. We all know if the patient is conscious and able and willing for the oral treatment with glucose tablets or glucose fluids, or the oral glucose can be given to prevent the hypoglycemic in a conscious patient. And the rule is of 15-15. Means if 15 grams of glucose to be given every 15 minutes. Once the patient achieves a normal blood sugar, we should advise the patient to take a meal or the snack to prevent the further recurrence of the hypoglycemia. If the patient is unconscious, unable or unwilling to take orally IV administration of the glucose, initially with the 25 grams of the glucose infusion and followed by the 10% infusion should be given. Repeated serial plasma glucose should be measured, and accordingly the patient is advised, once the patient starts taking orally, can be switched to oral treatment. A word about the glucagon here. If IV therapy is not possible, subcutaneous or IM or even nasal glucagon can be used. But glucagon is to be avoided in patients who are on the sulfonylurea-induced hypoglycemia, because this glucagon itself leads to an insulin secretion and then it is further potentiates it. So it should not be used. We have to consider the drugs what the patient is taking already and review the drugs history of the patient and to prevent the hypoglycemic. The modern insulins, they should be used instead of the traditional ones because they have increased risk of hypoglycemia. Insulin pumps may also reduce the risk of low blood glucose level, but simultaneously, if it is high dose injected accidentally, too much of insulin, or it is in the muscle, can cause a low blood sugar also. We should give a proper education to the patient about the insulin timings, dosage, and meals, and a regular exercise program if the patient is on the insulin therapy. The long-acting sulfonylureas, they should be especially avoided in the elderly population. If at all there is no other choice, we can use a short-acting sulfonylureas such as the glipizide and the gliclazide. Similarly, isodenias are also not preferred in the elderly patients. The drugs which can be preferred in the elderly patients are that metformin is the first line of the agent. It can be given in the type 2 diabetes patients. If the GFR, calculated GFR is at least 30 ml per minute per square meter, but it is contraindicated in advanced renal insufficiency and the patient who has a heart failure and the hepatic dysfunction because of the lactic acidosis, it should be given with cautiously. Preferred drugs are the incretin-based therapy, that is the DPP-4 inhibitors such as the gliptins. They have a fewer side effects and minimal risk of hypoglycemia. But the problem is there with the cost factor. But now there are many drugs which are also coming in the affordable cost. So this drug should be preferred to start with in a elderly diabetic. GLP-1 receptor agonists as the glutides, they have an additional benefit of a cardiovascular benefit is there. So any patient has associated cardiovascular disease or has an established higher ASCVD risk factors, these drugs should be preferred. Similarly, SGLT2 inhibitors, glyphosons can also be safely prescribed in the elderly patients, and they also have a cardiovascular benefits. So with this all, just a remarks over the clinical features, treatment part. There are recommendations by ADA 2023 guidelines for this, especially for the hypoglycemia and elderly. And I'll just go through it because older adults with diabetes have a greater risk of hypoglycemia than the younger adults. Typical source of hypoglycemia should be ascertained and should be monitored in every visit of the patient. That is a class B indication. A and B and these are the classes written. For older adults with type 1 diabetes, continuous glucose monitoring is mandatory. And similarly, older adults with type 2 diabetes and daily doses of insulin, multiple daily doses of insulin. Again, continuous glucose monitoring is mandatory, but I think this is not much in the practice. I don't know how many our patients are on this continuous glucose monitoring devices. I have also not seen any patient. For older adults with type 1 diabetes, consider the use of the automated insulin systems. These are the guidelines by the recommendations by the ADA. And the treatment guidelines to prevent hypoglycemia in older adults with type 2 diabetes of increased risk of hypoglycemia, medication classes with low risk of hypoglycemia are preferred. Over treatment of diabetes is common in older adults and should be avoided. Simultaneously, de-intensification of the treatment goal is recommended to reduce the risk of the hypoglycemia if it can be achieved within the A1C target level. There has to be simplification of the complex treatment plans to reduce the risk of hypoglycemia, polypharmacy, and decrease the burden of the disease. And we should see with the simplification of the treatment, if we can achieve an A1C target, the treatment plan should be simplified. Lastly, we can consider the cost of care and the insurance coverage, etc., because adherence to the treatment is most important, and that will be based on the treatment cost. The treatment goals which can be kept for an elderly patient are that if the patient is healthy, there are few coexisting cardiac illnesses, chronic illnesses, their cognition is intact, we can target the HbA1c level up to 7 or 7.5, below that also. But if the patient has a complex health, intermediate, there are multiple coexisting illnesses, if cognition is impaired, which is mild to moderate, the target HbA1c should be less than 8%. But if the patient has a very complex or the poor health, end-stage renal, end-stage chronic diseases, patient has a severe cognitive impairment, we should not rely on the A1C levels. We should try to maintain the blood glucose in the range of 100 to 180. So this is nothing, just I'll skip out this slide. The take-home message is that start with the low with the geriatric friendly drugs and proceed slow. That is one. Patient and caregiver education, monitoring, and regular follow-ups are mandatory because we might be missing a blood glucose level and the subclinical hypoglycemia, which can again patient can come to you with an emergency with the almost unconscious stage. Tailor the treatment according to the individual needs to achieve the optimal glycemic control. There should be an optimal glycemic control, and that optimal glycemic control depends upon the patient's individual health, associated chronic diseases, and the cognition of the patient. We should not try to achieve a targeted that this A1C level has to be achieved like a younger population. Cost-effective and simplified regimes improves the adherence to the treatment because elderly patients are always having short of these problems. They are more or less dependent on the family members. Nutritional care, regular exercise, and social support are integral part of the management. Care of polypharmacy and de-intensification of the treatment regime should be done whenever required. Screen for early detection of neurocognitive impairment, dementia, and frailty in every elderly diabetic, because these geriatric syndromes, they compromise the abilities of older diabetics to self-care of their disease and ultimately leads to a dependency on a caregiver. More the dependency, more will be the episodes of hypoglycemia, maybe more will be the episodes of complications. Improving subjective well-being and quality of life is an essential care component in an elderly patient. That finishes with my talk. Thank you very much for the patient hearing and giving me this opportunity once again. Thank you.
Thank you so much, ma'am, for this wonderful deliberation on hypoglycemia in the elderly population, for your insights, and you've covered every aspect of it so well. Now that we have discussed about the geriatric syndromes, the impact of hypoglycemia, let's understand a little more about what are the recommendations in the standard of care? What do the guidelines say? And for that, I invite a very dynamic speaker, Dr. Pratap Jetwani, who's been a very active member of this group. And Sir actually needs no introduction, but he's a director and consultant at Jetwani Diabetes Care Center, Rajkot. He's the chairman, Gujarat State Chapter of RSSDI, presently National Joint Secretary, RSSDI, and past executive member of RSSDI.
You can skip this, Zami. We can
okay. Okay, sir. I hand over the forum to Sir now. He will take us through discussing about the standard of care in the geriatric population. Over to you, sir.
Thank you. Thank you, Ami, for kind introduction. I think some of my part was already covered in the previous talk, so I will rush through my slides because I think we are running late by almost 10 minutes. So we can spare 10-15 minutes for discussion. I hope my slides are visible.
Yes, sir. Yes, sir.
Okay, fine. So today I will be speaking on geriatric syndromes focus recommendations in standard of care. And we all know that around 25% of people over the age of 65 years, this is as per the US data, they have diabetes, and almost 50% they are having pre-diabetes, and this is increasing rapidly in older individuals. And the management in these individuals is very complex because it requires assessment not only of medical condition, but also about functional status, psychological status, as well as various social domains also. These people, they are at higher rates of premature death, disability, accelerated muscle loss, multiple coexisting illnesses, comorbidities such as hypertension, cardiovascular disease than those without diabetes. And they are also at greater risk of common geriatric syndromes, which already highlighted by Professor Vinod Kumar. This is the US data by 60 to 69 years of age. If we take diabetes, almost 50% they are having diabetes more than 10 years duration. But if we go beyond 80, this will increase to 75%. So most of the people in elderly, they are having long-standing diabetes. So they might be having a lot of microvascular as well as macrovascular complications as highlighted in this graph. And this is data from US Veterans Affairs. These are the common geriatric syndromes which are being observed in aging population. And these are also common in people who are already having type 2 diabetes also. Cardiovascular disease, cognitive decline, depression, polypharmacy, falls, fractures, and disability and urinary incontinence. These are the few geriatric syndromes which are common in people who are having diabetes. And there is a lot of interaction between geriatric syndromes, diabetes complications, and various comorbidities which are there in these individuals. And ultimately, they increase the risk of frailty, disability, morbidity, and mortality in these elderly people who are suffering already from diabetes. So what do the recommendations say? I will just start with ADA recommendations. These are of 2023. First, they say that consider the assessment of not only medical, but psychological, functional that they mean by self-management abilities and social domains in older adults, so that you can determine targets and you can determine various therapies for diabetes management in this group of patients. Because elderly, this is a very heterogeneous group of people. Screen for geriatric syndromes in older adults, as they may affect diabetes self-management and they may diminish quality of life, as already highlighted by Professor Vinod Kumar in his presentation. They also recommend that mild cognitive impairment should be performed. The screening should be performed for adults who are 65 years of age or older at the initial visit, annually, and then as appropriate depending on the circumstances, because elderly, particularly during acute illness or following acute illness, they are at risk of developing mild cognitive impairment. So this may be required much more frequently if they land with hypoglycemia or if they land with any kind of an acute illness, including infection. Regarding risk of hypoglycemia, definitely these people, they are at line, and all these things to get frequent hypoglycemic events. It is a heterogeneous group of people, detect cognitive function, and then the glycemic hypoglycemia, because now we have got variety of drugs where you can reach HbA1c even below 7 without increasing the risk of severe hypoglycemia. And these are the preprandial and bedtime glucose goals. Particularly bedtime glucose is to be kept between 80 to 180. I think generally in clinical practice, we keep it between 100 to 180, even not 80 to 180. Blood illness impairment, then at the same time, blood pressure target remains same. At the same time, blood pressure target remains same, and statin should be continued. As compared to the very complex or poor health elderly people who are either having end-stage poor health, elderly people who are either having end-stage chronic illnesses, avoid hypoglycemia, and at the same time to avoid symptomatic hypoglycemia, and at the same time to avoid symptomatic hyperglycemia, which can increase the risk of dehydration in this category of patients. And if you see, the fasting glucose should be between 100 to 180, and bedtime should be 110 to 200. And blood pressure goal is also relaxed in these individuals, and statin is generally not considered because the overall life expectancy is very short. So you cannot reap benefits of statin therapy in this category of patients. If they are already on statin, you may continue. New starting of statins is generally not indicated in this category of patients. ADA has also touched upon when to simplify therapy and when to de-intensify or de-prescribe therapy. So if we see the healthy group, if they are having severe or recurrent hypoglycemias, particularly they are on insulin therapy, then you need to simplify therapy. Particularly if it is a complex insulin therapy, you need to simplify it, and you need to use agents which are associated with less risk of hypoglycemia. If there are wide glycemic excursions, and if cognitive or functional decline it occurs following any acute illness, even in these healthy individuals, then you need to simplify therapy. Otherwise, they are at risk of dosing errors, they are at risk of administration errors, they are at risk of drug interactions. De-intensification should be done if the patient is having severe or recurrent hypoglycemia in spite of being on non-insulin therapies, and they are having wide glycemic excursions, or they are receiving polypharmacy. Then in those cases, you have to think of de-intensifying or de-prescribing few of the agents which are not required or which are not having any evidence-based support to be continued in elderly. The second group where you are targeting HbA1c less than 8, the same applies here. If insulin therapy is being used and patient is having severe or recurrent hypoglycemia, you have to simplify therapy. If the patient is not able to manage complexity of an insulin regime, then you have to modify it. And if there is a significant change in social circumstances, such as loss of caregiver, if there is a change in living situation or financial difficulties, then you need to simplify therapy. And for de-intensification or de-prescribing, the same ideas which are there for healthy, that is severe hypoglycemia and non-insulin therapies, wide glycemic excursions, and polypharmacy, then you have to de-intensify or de-prescribe the therapy. If the people, they are community dwelling patients receiving care in a skilled nursing facility for short-term rehabilitation, or we have admitted those elderly patients and now we are discharging them then you have to focus these patients. You have to monitor their blood glucose very regularly during the early period after discharge, and you have to simplify therapy because they are at risk of administration and dosing errors. They are at risk of developing severe hypoglycemia, and also you have to consider the type of support the patient will receive at home when you are planning a treatment on discharge for this category of patients. Very poor health patients or at the end of life care, at the end of life patients, then you have to avoid reliance on A1C, and your focus should be only on to avoid hypoglycemia as well as to avoid symptomatic hyperglycemia. And I think here you have to use the simplest therapies just to sustain life and to avoid the extremes of blood glucose excursions in this category of patients. As far as Diabetes Canada guidelines are concerned, they are published in 2018 and they have relied upon clinical frailty index, which I will touch upon in subsequent slide. If the clinical frailty index is between 1 to 3, the patients are considered functionally independent. Here also they have considered the use of therapies which are associated with increased risk of hypoglycemia in elderly people. So if the patient is not on insulin or sulfonylurea, one may go for an HbA1c below 7 in this category of patients. But if the patient is on insulin or sulfonylurea, whether they are functionally independent or dependent, the target should be between 7.1 to 7.5. If they are functionally dependent, then HbA1c goal should be less than 8. But if they are on insulin or sulfonylurea, the HbA1c is to be kept above 7. If HbA1c goes below 7, the risk of hypoglycemia increases in this category of patients. And that's why Diabetes Canada, they recommend to keep it above 7 and less than 8 in functionally dependent patients. Frail patients or those who are having dementia, you have to keep it between 7.1 to 8.5 if they are on insulin or sulfonylurea. Otherwise, you have to keep below 8.5. And if you are able to reach even below 7.5 with good therapies, you can reach their target. And end of life care, the same recommendations as per the ADA, they are being followed by Diabetes Canada. And this is the clinical frailty index which they use for classifying elderly individuals in various groups so that you can utilize, you can decide the target for a given individual. You can go through this, that is available on website. It's very busy slide, I will not go through it. Another guidelines by Endocrine Society which were published in 2019. This is treatment of diabetes in older adults, and they have divided patients in 3 groups. So the first group is good health, and intermediate health, and third is poor health. So good health people, they are not having any comorbidities or 1 or 2 non-diabetic chronic illnesses and no activities of daily living impairment and less than 1 instrumental activities of daily living impairment. So what do you mean by this ADL and IADL? ADL is activities of daily living, and that includes bathing, dressing, eating, toileting, and transferring. Whereas instrumental activities of daily living, they include preparing meals or shopping or managing money or using the telephone and managing medications. So if they are not having only 1 or less instrumental activity of daily living impairment, no ADL impairment, and either no comorbidities or 1 to 2 non-diabetes chronic illnesses, they are in good health. You can go for HbA1c. Again, if the patient is on glinides, sulfonylurea or insulin, you have to target HbA1c below 7.5 but above 7. And if they are not on this therapies which cause hypoglycemia, you have to target HbA1c below 7.5. Intermediate group is where there are 3 or more non-diabetes chronic illnesses, along with or without mild cognitive impairment or early dementia, or 2 or more instrumental activities of daily living impairment. There the target is up to 8. And if the patient is on hypoglycemia causing therapies, then you have to keep HbA1c above 7.5 all the time. Poor health patients are those who are having end-stage medical conditions like metastatic cancer, oxygen-dependent lung disease, end-stage kidney disease requiring dialysis and advanced heart failure, or they are having moderate to severe dementia, or they are having more than 2 activities of daily living impairments, or they are residing in a long-term nursing facility, then they are of poor health. Here the target is 8.5. And if they are on hypoglycemia causing therapies, then it should be between 8 and 8.5. So this was about older adults guidelines by Endocrine Society. And IDF also goes along with, like Diabetes Canada, that is functionally independent 7 to 7.5%. If they are dependent, then 7 to 8%. Sublevel frailty less than 8.5%, sublevel dementia less than 8.5%, and end of life, all agree same, avoid symptomatic hyperglycemia as well as hypoglycemia. I think Madam has already touched upon about various drugs which are to be used in elderly people. Metformin you can use, but keep watch on renal function. And during acute illness, you have to stop this medication, because if the patient is having shock or hypoxia or something like that, the risk of lactic acidosis increases, particularly in the setting of acute kidney injury. Glitazones are generally avoided because of the risk of fractures and CHF in elderly people. Long-acting sulfonylureas are to be avoided. Short-acting are to be preferred. And best drugs which are to be used if you want to use a secretagogue, then they are glinides, because they are having very short half-life. And the hypoglycemia, it occurs, it is very short-lived. But they are also to be avoided, particularly in end-stage kidney disease or when the GFR goes below 30. DPP-4 inhibitors, these are the molecules which are to be used very often in elderly, because they are not associated with hypoglycemia, they do not produce weight loss, and they are not having many serious side effects. You can use these agents even in the setting of renal dysfunction. Linagliptin does not require dose modification. All other you can use in a modified dose even in the setting of CKD. SGLT2 inhibitors already covered by Madam, but you have to keep in mind that in elderly frail people, they increase the risk of dehydration and postural hypotension. So you have to counsel them about hydration and various other things. GLP and insulin already covered by Madam. I will just touch upon whenever the patient is on insulin therapy and the patient is developing recurrent hypoglycemia or severe hypoglycemia, and you need to simplify complex insulin. Simple 100 to 150, or even you can keep 100 to 160 and increase dose by 2 units every 5 to 7 days and decrease dose by 2 units depending on the fasting plasma glucose. If the patient is on premix insulin therapy, which is very much detrimental in elderly people, and I will suggest that don't put any elderly on premix insulin. Better is to use basal with oral drugs so that you can provide them appropriate glycemic control without increasing the risk of hypoglycemia, and also at the same time avoiding symptomatic hyperglycemia. If they are on premix insulin, then use 70% of total dose as basal insulin only in the morning, and you have to shift them to a basal insulin. Now, if they are on prandial insulin and they are having hypoglycemia, then if the dose is more than 10 units per meal, then you have to decrease dose by 50% and add non-insulin agent. If they are already on less than 10 units per dose, then you can discontinue this and add non-insulin agents whenever you are simplifying insulin therapy. And particularly when eGFR is more than 45, you can start with metformin. You can even start with DPP-4 inhibitor when you stop this prandial insulin, and if required, you can even start with lowest possible dose of glinides in this category of patients to cover postprandial glycemic excursions, and AGIs are also wonderful agents if they tolerate them. For prandial insulin, if you have to use, then you do not use rapid and short-acting insulin at bedtime. And you have to follow a very simple regime. If the prandial pre-meal glucose is more than 250, when you want to avoid symptomatic hyperglycemia, when it is more than 250, give 2 units of short or rapid-acting insulin. If it is more than 350, give 4 units of short or rapid-acting insulin. And you have to stop this sliding scale when not needed daily. So this is the way you have to simplify insulin therapy in elderly people who are on complex insulin therapies and who develop recurrent or severe hypoglycemia. To conclude, I will say older adults with diabetes, they are not having only medical complications. or medical conditions. They are also having physical problems with physical functioning, cognitive decline, and geriatric syndromes. And you have to decide whether this is consistent with the whole picture. Is the patient capable of implementing self-management decisions? Is the patient capable of detecting, treating, and preventing hypoglycemia? And depending on that, you have to decide targets, you have to devise strategies, taking into account the various pharmacotherapies which are there available in our armamentarium. Particularly in geriatrics, you have to engage family, system, and social resources, and you have to screen these people at regular intervals for geriatric syndromes and try to prevent those syndromes. And if they are present, then try to control them with minimal intervention. Telemedicine is a boon for this category of patients. If they are not able to visit hospital facilities, they can link with providers, and you can monitor, support, and educate not only patients, but their family members, their caregivers. You can educate them, you can provide them treatment decision support, you can monitor their progress, and that way you can provide them a better control without increasing the risk of glycemic excursions, be it low or high, and at the same time improving quality of life. And always keep focus on nutrition, metabolism, sleep, stress, and inflammation also in this category of patients. And another important thing, these people, they are at high risk of developing hypoglycemia, they are at high risk of developing acute illnesses, and a minor acute illness, even a simple viral infection can be dangerous for this category of elderly people. And then you have to reevaluate condition, and you have to reevaluate targets and strategies depending on the condition in which the elderly they are brought to you. So it is a heterogeneous population. You have to individualize therapy depending on the various points which I have highlighted from various guidelines, be it ADA, Endocrine Society, or Diabetes Canada. And if we can improve their care, we can give them a graceful aging. Thank you very much. Dr. Ami, are you there?
Sorry, sir. There was some technical issue. So, thank you so much, sir, for this wonderful insights on the standard of care recommendations covering each and every aspect. Now we are open to questions from the audience, and if anyone from our faculty wants to discuss something, you're most welcome to do that.
I would like to, first of all, I would like to thank all the speakers for the lucid and wonderful, very informative talks on these topics related to the elderly. Actually, they form a large portion of our patients, and such educative seminars, webinars are very important, and I'm sure they would be of great use to all us practitioners practicing diabetes. To add here, and I would request the opinion of all the panelists here. One is that I have personally noted in my practice that sepsis, infections, they form a big chunk of hypoglycemias that we see in our practice, especially in males. They have urosepsis because of untreated or not properly treating UTIs, which are caused by prostatomegaly. So I think this is one point we should always have in mind, together with the medications and the other reasons which are causing hypoglycemia, that infections and sepsis, specifically urosepsis, can also be a big cause in causing hypoglycemia. Would anyone like to comment, sir?
May I?
Yes, ma'am.
That's what I had made a passing reference to elderly patients who may not be even diabetic, but they are at risk of hypoglycemia because of the old age itself. Then the urosepsis is very common, as you said. Any acute illness, they can have they can develop hypoglycemia because multiple reasons. The disease itself, maybe that their oral intake falls also simultaneously. They are not maintaining their adequate nutrition, not being taken care of from a maybe socially isolated. So, and on the top of it, if the drugs you can give, and I think we should antibiotics also, few of the antibiotics, and especially the quinolones, I think they can give rise to hypoglycemia. And so we should think of all these drugs also. Maybe the patient is already taking some other drugs like NSAIDs also, they can cause hypoglycemia. So the drugs, sepsis, nutrition, that all matters. Even if the patient is not a diabetic, can develop and because of itself, because of the sepsis also, that can be there. That's true.
Ma'am, talking of drugs and anti-diabetic, actually, and urosepsis, I think we should pay more attention to SGLT2s. Dr. Jetwani had touched upon this passingly when he was showing the slide about SGLT2, that we should be very careful with SGLT2 inhibitors, even though they don't cause hypoglycemia per se. But I feel that in elderly, there are many other aspects of this drug which don't make them the best suitable option. As he mentioned, they may cause hypotension, postural hypotension, electrolyte disturbances, and then urosepsis is, I think, one of the biggest problems that both maybe the males and the females.
I agree with you. I agree with you, Rajesh. And I think we should give this clear message to all elderly people that whenever they develop any kind of acute illness, I think they have to stop all oral anti-diabetic agents except DPP-4 inhibitors, which they can continue if required. Otherwise, everything they have to stop. They have to keep monitoring their blood glucose. And if required, they are to be put on insulin therapy, whether at home or in a hospital setting, and that also in a simpler way, so that we don't make many of that errors and increase the risk of hypoglycemia. But the patients who are on OPD basis, we should advise them any acute illness, SGLT2, even if it is not UTI, any acute illness, if oral intake is down, stop. Even metformin, they have to stop. So almost all drugs they have to stop, except DPP-4.
The disadvantage with SGLT is that the passage of the large amount of urine, they have to go frequently. And so we have to decide, we have to really assess how capable they are to frequently visit the urine for the urination. And that itself might be a very troublesome for most of the elderly persons.
Many they are already having urinary incontinence, so that will
they're already frail, and again weight loss on top of that. So I think probably above the age of 65, 70, and in lean diabetics, SGLT2.
Although it has got a good evidence as far as cardiorenal protection is concerned, but then you have to judge it against the risks which are associated with therapies and overall life expectancy, overall functional status, everything you have to take into account when you are using these molecules, which I think like a double-edged sword in this category of patients.
One more thing I wanted to bring out here, that one thing I've noted is that in
just a minute, Rajesh, just a minute. Ankit, if there are any questions from the delegates, please share in the chat box or somewhere so that we can ask those questions also during this discussion. Yes, Rajesh. Continue.
Okay, so one thing I wanted to share is that one problem that I see in the elderly, and especially elderly diabetics, is the mood disorders, the psychiatric conditions which are there with age. I think they also need to be dealt with, just as we are dealing in diabetes and with cholesterol or blood pressure. Because what happens is that this affects their compliance. This makes them socially isolated, and this takes them away from the society, so they're not being able to integrate. And the people, even the caregivers also at times, they start from the elder, from the diabetics, they're not able to give proper because of these mood problems. So I think they also need to be made a part of the treatment. When we have elderly diabetics, they should be assessed for these problems, and the family and the caregivers should be told that probably they need a psychiatric consultation or some psychiatric medications. They should be part and parcel of management of diabetes in elderly.
Agree with you. Ankit, are there any questions from delegates? RX teams?
How many
Yes, sir.
delegates might have registered? Any idea? And actually, how many delegates have attended today's webinar?
Sir, they will share the report probably by tomorrow morning. I will share with you once they share the report with me.
Other thing is, this whole webinar was recorded, was it?
Yeah, it is being recorded. It is being
Is there
recorded.
any way to spread this webinars recording to different people, because very few have attended as far as the faculty or delegate have attended are concerned?
Yeah.
Are there any steps that we can take to spread this webinar video recording to others? Is it possible?
I think we will share with Amit so that he can share with other groups also, and if it is possible to keep it on Diabetes India website or somewhere, then we will keep it there also.
Okay.
So that more number of people can avail benefit of this webinar.
What I could smell here, that in spite of very few people attending this, and particularly the faculty, I think very useful points have come out in the discussion. I mean, after all the three presentations, the discussion which has taken place, 2 points that Dr. Rajesh Kesari has said about the sepsis, urosepsis, and about the psychiatric evaluation, etc., and equally befitting explanation given by Dr. Meenakshi Sharda about the various contributing factors which can lead to hypoglycemia in elderly people, even in non-diabetic. These are practical problems which are nowhere written in the guidelines, nor we as diabetologists we talk about it. So I think what Dr. Meenakshi was talking, she was talking from her experience as a geriatrician, because she caters to a lot of people in old age and what all kinds of problems they are facing. So I think these joint exercises are very, very useful. And otherwise, what we normally do, we talk of stereotype presentations and all that, but the practical implications are so huge. Dr. Rajesh Kesari shared his experience, what he is encountering, and Meenakshi ji has also shared. So these are very important. And I think if the video is shared with others, this video should be shared not only for presentation point of view, but from the discussion point of view that has followed. This is also equally important. So that is what I think. And so I am very happy that it has been a very good webinar. And I would just like to, I was scratching my head for what could be the topic, the next webinar. Of course, we can talk in our meeting. But I was, one of the things that I was thinking, again, a collaborative exercise between diabetologists and geriatricians could be on a topic like diabetes and longevity, something like that. Because there are two reasons why I am talking of this topic. One is there are certain anti-diabetic drugs like metformin and ecaribos, which are undergoing trials as anti-aging drugs. I'm not talking of all the drugs which improve the diabetes control and thereby promote the health and longevity. I'm talking of really genuinely anti-aging drugs, some of which are anti-diabetic also. That is one. Then there are studies also going on how to increase the longevity of diabetes with different kinds of levels of control. For example, they say that if somebody has a HbA1c of say 7 or 7.5, further maneuvering can lead to his longevity, life expectancy can increase by 3 years. And those who have got an HbA1c of 9 and LDL of 145, thereby maneuvering, you can increase the life expectancy by 10 years. So all those things are important to consider. So maybe this is one topic, but of course I leave it to the intellectual ability of others. We have already discussed, so we'll finalize that thing also. But I personally am very much convinced that there are topics which we can introduce in these webinars, which are not the traditional topics, not the tailored topics, something very different, out of the box, something like that. So that is what I would say, and I don't have anything else to say. But I would be interested, Dr. Jetwani, to find out how many delegates have attended. stop.
Sir, there are a couple of questions. One was on the YouTube link, which I just read. Can I read out the question, sir?
Yes.
Sure.
So there is a question by Mr. Chetan that please address about the use of antiplatelet therapy in the geriatric age group, especially 80 plus, who have a good control of hypertension, no diabetes, or increase in lipids. So they want to know the use of antiplatelet agents.
Well, general principle has been for many years that the concept has now changed, but for many years, people were indiscriminately writing aspirin for people above the age of 60 or 65 purely for prophylactic reasons. I think this concept has changed. Now, aspirin prophylaxis is only given to people who had some kind of a transient stroke or heart attack in the past. But after the age of 80, now the present concept to my mind is after the age of 80, aspirin should be stopped. If it is not stopped, it can create intracranial hemorrhage, and it is given after the age of 80 only for secondary prophylaxis. If somebody has suffered already from something, then he may continue under medical supervision, but not indiscriminate use of aspirin even above the age of 80, which was going on for so many years. I think somebody else can also tell us.
May I add something on this?
Yes, sure.
And practically it is seen, as you said, the clinical practice is different, and really which we read in the books and guidelines are maybe not applicable to every individual. And practically we had seen the many geriatric patients are coming with the severe anemia, and that is because of the maybe aspirin induced. They had been taking for something, and then they get lined up with the such a severe anemia that blood transfusion has to be given. So, as you said correctly, just as hypertension, no role of antiplatelet drugs, and especially in the very elderly population, we are not going to give a much benefit of prophylaxis also. I think it is not recommended now. That's what I wanted to say.
I would also suggest that somewhere in our group, because it's a diabetes and elderly group, RSSDI did make recommendations in 2022 about the guidelines and recommendations for care of diabetes in elderly, and Dr. Jetwani was a part of the overall recommendation, which is, I think, under 34-page document or something like that. And in that document, there are, I think, 15 to 20 pages which are devoted to the chapter on recommendation for diabetes in elderly. So we also have our own recommendations from RSSDI, and these can be intimated to our group at least as a separate one, not the entire group. Entire recommendation already printed in our International Journal of Diabetes in Developing Country, no doubt about that. But just for information's sake, if you like, I can extract out that 20 pages purely for diabetes and elderly care recommendation, and they can be shared also in the group and even outside the group if it is necessary.
Yes, sir. Yes.
There is one more question in the chat box. Dr. Amy, please, you can.
Yeah. So they were discussing about the management of fall, especially post midnight, putting back to bed, what we see usually in elderly population. So any comments on that?
Dr. Sharda, you would like to say, or I can, as you like. You are muted, Dr. Sharda.
Yes, sir. Please, you go ahead, sir. I don't want to comment on this.
Well, falls is a real problem, and there are multiple causes as I tried to enumerate. There are questionnaires and instruments for what is called falls assessment. After the age of 65 or any age that you can have a cutoff point, every elderly, where I'm talking of general elderly, not specifically for diabetic elderly, where it is even more common, every elderly undergoes, in addition to what is called comprehensive geriatric assessment, he also undergoes in a geriatric clinic assessment for cognitive impairment, for frailty assessment, and also in advanced centers, he undergoes what is called falls assessment. If somebody is vulnerable to a fall, before he falls further and he has recurrent falls again and again, much before that, if he falls into the category of susceptible to recurrent falls, then the proper prophylactic measures are to be taken. They could be anything like finding out the bone density, finding out the level of exercise, whether he's sitting all the time, not taking exercise, whether he's vitamin D deficient, or any other nutritional supplement that may have been needed. Even proteins are important for osteoporosis. So all those things have to be taken into account and one can prevent. But once the fall has taken place, it is a signal for future prevention. But if a fracture has taken place, of course the fracture has to be treated. But after the fracture is healed, one has to again check for any falls assessment or for any susceptibility to falls and fracture, and all those measures have to be taken. They are all written up. Guidelines are also there for fall assessment as well as fall prevention.
So if now this question is about management of fall from bed. I think, as you said, that very rightly, that the assessment of medication should also be done, because of lot of elderly probably with CKD, hypertension could be, or because of pressure or BPH could be on alpha blockers. So postural hypertension should be ruled out in such cases, especially rising up from bed. And little bit of training to the patient and to the family members should be given about how to get up from the bed. I think these small things about how to get up from the bed, how to behave in the toilet, not getting up immediately. These are very, very small things. If we tell the caregivers, the family members, they can be very helpful in preventing such falls either from bed or in toilet or at such places.
Actually, Dr. Sharda would vouch for me that all these, whatever small points you are saying, they are very important points. And Dr. Sharda would vouch for me that everything of this is a part of geriatric care. And when an elderly individual comes to a geriatrician, they are all, it is not just a question of informally telling him, but it is well tailored exercise, or everything is written up. And I think that applies even more to those elderly who have diabetes also. So it's a huge thing. And I think one big instrument which should be introduced for diabetes elderly is comprehensive geriatric assessment. This is just a 10 minutes or even 7 minutes office procedure where you find out what is the mobility of the individual, what is his cognitive impairment, whether he has urinary incontinence, what is his nutritional assessment, what is his social environment, what is his psychological status. It can all be done in 5 to 7 minutes. That is what we had been doing at All India Institute of Medical Sciences. And once there is any deficit on such a screening, that deficit has to be further looked into either by the geriatrician itself or by the concerned expert after proper referral. So I would say that Dr. Meenakshi Sharda might like to further react on this. Yes.
I just want, his question was something putting back to the bed. I didn't understand his question. Probably what he wants, putting back to the bed. I don't know what, I'm not able to understand what Mr. Bhati, it is Bhanti wants to know.
What Dr. Kesari is saying that, for example, when an elderly individual gets up in the night and goes to toilet, so while getting up from his bed, if he suddenly gets on the bed and he starts walking,
that is true.
Then he is likely to fall and he is likely to have injury. So such people have to be taught how to get up from the bed.
Yes, 100%.
And then wait for 1 minute, half a minute, and then only get up and then walk slowly in a relatively lighted up environment. Those kinds of things are important because fall is a very bad thing. So many people die in old age because of fall. And this Amrish Puri and this singer, ghazal singer Jagjit Singh and Sunil Dutt, these are some of these people who died during falls in bathroom. So this is very important, and that also brings up the question how a bathroom should be protective for the elderly. They should not be slippery. There should be hand grips for getting up from the toilet, those kinds of things. So it's all geriatric, it's all geriatric. And it is more applicable to elderly, to diabetic people.
I think we will keep a separate seminar related to bone health and fractures, particularly in elderly, because that is a very big issue where we have to focus on osteoporosis also, falls prevention, various questionnaires which are to be used to identify individuals who are at risk of falls, at risk of fractures. So this should be a separate webinar, and I think we have already reached 9:22 p.m. So I will request Dr. Ami to conclude because we have already crossed our time limit by 15-20 minutes.
So this can be, just a moment, with your permission. Sir, whatever you were telling just now could be a part of the next webinar, a 10-minute workshop, which you can give about the assessment of elderly. So it would be even more interesting, together with whatever topic we are going to decide. A workshop would be very interesting.
I can give even just now. It is in my tips. But anyway, time is up, so we can do it. And I would, because it will be comprehensive geriatric assessment. So I'm afraid where do we fit a diabetologist in that webinar? That is the problem, But we have to have a diabetologist speaker also there. So we would fit a diabetologist, no problem. But Dr. Sharda or someone else, I do not carry out these things anymore because I have retired from the All India Institute of Medical Sciences. But I can speak. I have a lot of habit of speaking unnecessary things also. So I can speak. So we can have it. No, if everybody agrees, we can have a seminar. It's very important. And I might also bring out a point here that one of the functions of an interest group is to produce a white paper or a position paper. And I have already written, it is in black and white, that I would be writing the position paper with the collaboration of some of my colleagues. And in that collaboration paper, I have already identified some sub-items. One of the sub-items is comprehensive geriatric assessment of elderly.
Thank you, sir.
Oh, thank you, sir. So can I conclude now?
Sure.
Yeah. Okay. So I think with this real brainstorming session by our real esteemed panelists, Dr. Professor Vinod Kumar, Dr. Meenakshi, Dr. Pratap Jetwani, Dr. Rajesh Kesari, and everyone else who had an active participation, I thank you all for being a part of this webinar. And above all, a big thank you to Dr. Bansi Saboo, Dr. Amit Gupta for helping us make these teams and organizing these webinars. And a big thank you to RX Events for helping us to organize this whole event today evening. So just a last remark that collaboration between healthcare professionals, caregivers, and the elderly themselves is the key to addressing these challenges successfully. So thank you for your participation. Let's keep on raising awareness about various topics and sharing knowledge, and we meet soon. Till then, stay healthy, stay happy.
Good night. Good night, everyone. Thank you, sir. Thank you, sir. Good night, everyone.
Thank you, sir. Thank you, sir.
Bye-bye.
Okay, bye.
Recording stopped.